Thank you for showing interest in our research and joining us. I'm the head of the Neuropsychiatric Center in Munich, Germany, in Riem. This is the part of Munich where we have our head center, and we also have a second center, also a psychiatric healthcare center in the middle of Munich. Today we want to talk to you about our research. We did several different aspects about the immigrants we treat. First, I would like to introduce you our center. We are 7 consultants. We are mainly immigrants working here, psychiatry, neurology, psychosomatic diseases, and psychotherapy. Obviously, we do also psychotherapy, and we treat in 10 languages, and we also have a lot of immigrants coming to us. I would say about 60–70% of our more than 2,000 cases within 3 months have a migration background. And today we want to show you what we found out so far about gender patterns in the people who come to us in their different psychiatric diseases. And also we want to show you different aspects of their disease. Are there more sick immigrants? What's their ages, and so forth. In the background, once in a while, you can see a part of my co-author, Rahman Demirkol, who is my research assistant and very helpful. And thank you so much to him for preparing this presentation. And also Jonas Miller is supposed to join us in this talk, who did mainly our statistics and is also a co-author of this paper. In this special poster we want to show you today, we focused basically on the gender difference, and also, first of all, the vulnerability of mental disorders in immigrants. Immigrant men have difficulties going to a doctor when they have psychological problems. Even in Germany, even today, the impact of the gender roles is still important, and it's detected through social and cultural parameters. And the migration status as well is difficult when we treat psychological diseases. As you know, in the 60s, 70s, most of the immigrants came to Germany. They were actually invited to come to help to rebuild German economy, because after war, in the wartime, everything was destroyed, and after war, we had sort of a wonder economy. Everything went well very fast. We had a lot of influx of money, and needed a lot of hands. And so mainly from Southern Europe, a lot of immigrants were invited to come to Germany. And one of the biggest groups actually joined from Turkey, and still the biggest group, besides the group of former German, outside Germany living people who came back to Germany. The biggest group is Turkish, or from Turkey, with different ethnic background. And these people were chosen thoroughly. Only 25% of those who applied were actually chosen. They were all healthy, mainly men, but now we have actually a 50-50 mixture of women and men in Germany from Turkey. And most people were young and healthy, and now within the last, let's say, 10 years, we have a huge influx into the healthcare system of people from with migration background who are now 50 plus and are getting more and more sick. And especially in psychiatry, we found out that if we have a mother tongue treatment, and we have, if we have culturally sensitive treatment of immigrants, then they really sort of come like a tsunami, we say. They really come in large numbers to try to get our help. In our center, we found out that we have way more than the known average. We have way more men being treated, and we have younger. The average of the immigrants who come to a psychiatric and psychotherapeutic treatment are younger than the normal German population mixture. Maybe I can also try to explain you what intercultural competence means. It's basically knowing about the different ways of communicating of people from other societies, how they talk about their diseases, and how they it's actually, there is no recipe how to treat people from other cultures. It's more the sensitivity. We are training doctors to not be afraid if there is any interference or any new interactional reality than they are used to with German patients. I'm training intercultural competency for several years now, and I introduced it into our healthcare system in Bavaria, and we have a lot of doctors who were trained by us, by me and my team, and we also want to publish more research and a book about the cases and how we treat them sensitively. And let's go back to what we did in this paper. We actually tried to give everybody who started psychotherapeutic treatment, mainly in the group. We also have a combination of group and individual sessions, and we have only individually treated patients. We have the SCL90R symptom score of patients who joined group therapy and also joined the combination of group and individual sessions, and only individual sessions therapy. And what did we do? We looked at these values. First of all, I want to tell you we had in this sample, but this is an ongoing research. We will show you later on next year a much larger amount of individuals we tested. In this poster, our current status was 124 group, 8 individual, and 15 both. That was the amount of people tested. And what did we see? We saw actually that we used multiple linear regression analysis to determine the associations between the questionnaire scales as criteria and variables such as gender, German language skills, and so on. Why did we use German language skills? We actually wanted to see how they react on culturally competent, trained German physicians giving German psychotherapy treatments. But what happened, our clientele, our patients, actually denied to go to a German therapist. They waited long time to be able to talk to a Turkish origin therapist in mother tongue. Even the second and third generation who's not really fluent in Turkish in Germany still wants to have a Turkish origin psychotherapist, because sometimes their conflicts with their families, with their mothers, fathers, are always culturally based, generational conflicts with the parents who might still not be able to talk German. So they tend to want therapist who is very familiar with their virtues, with their values, with their cultural background. So they feel more safe to talk about their problems. And they think that a Turkish origin therapist would be more loyal to their needs, which is questionable, but that's what they think. And so we couldn't even look at our one criteria we wanted to introduce in research. How is the German language skill proficiency, and is it a hindering factor for the treatment in German? So that's what's hopefully to come in the next sessions. The results so far, we did this SCL90R scales. We found significant predictors for gender, except in hostility and psychoticism. This is the two scales where we didn't find any significancy, but female gender predicted more the diseases, and they are more depressed, significantly more depressed than men. Or we could discuss that they show their depression more. And German proficiency, as we originally wanted to show, is not a factor in this research. That's why, understandable, we didn't have any significancies, because all the treatments were in mother tongue. So this is good to show that these scales are valid. So mother tongue cannot be a difference when we treat in mother tongue. So this is basically what we have as results. The gender of the participants and symptom scales, in particular depression, was significant. The German skills and other variables such as age, year of immigration, family status, employment status was not significant. If you look at the bars, you can see big differences. And I'm sure, I'm pretty positive that the statistics will be much cleaner and more valid when we have more cases, and then we will see significant differences. And in the next step, we will look more into the effectiveness of the psychotherapy, how we want to do that. We want to look at the same scales after having administered at least 80 sessions of therapy. So do we see any increase of the symptom scales after these sessions they got with us, group, combined, and individual? Could we make a difference, or is it maybe not enough? Because what we also found out in another paper, in another poster we presented last year, is that our immigrant patients are much younger. We have more men. We have people who are coming, 30% of our patients, which is very not typical in Germany. People go to a doctor who's right next door, but our patients, they come to us from more than 100 kilometers distance, even more, some from 200, some from 300, because they don't have any other doctor in a German system where they can be treated with their insurance card, with their insurance company, but still speak Turkish besides all the other languages we have. But this is really important. We have a lot of patients who come from far away and who also finish their psychotherapy with us. This is also not typical. Mainly patients come, get stable. After half of the sessions, they stop the sessions and they abruptly finish their psychotherapy from their side in Germany. But our patients show that they are very much interested in our help and stay until the end. And they even want to go further. We have 12 sessions, again, 12 sessions, and then we can do about 35, and then we can do up to 80 sessions in group and in individual therapy. And our clientele, our patients, they tend to try to do all 80 sessions, which is very exceptional. That shows even this without looking at the SCL 90R scales, shows how much they need our help and how good they feel, so that they come from very far places to be treated with us. We think that immigrants have a very different way of behaving in group therapy than individualized patients in group therapy. Western patients tend to stay with their own needs and problems and focus on themselves and talk about themselves, and can also feel like some sort of competition between different patients wanting to talk about their needs in the group. And Turkish patients tend to be communitaristic. That means it's important for them to be in the group. They're used to be in the group. They wouldn't speak up easily. They want to be loved. They don't want to say no. And therefore, it's easier to treat an immigrant group from my perspective as a therapist. But it's also important to teach them to see them as individuals and be able to talk about their needs and their different types of conflicts within the family. So that's what I wanted to tell you so far. Are there any questions? You could look into our chat and try to give us questions. Rahman, my research assistant, is right next to me. He's looking at the chat function. We can try to answer your questions, and we are very happy to have feedback on our results and on our research.
You earlier mentioned that there is a significant relationship between gender of the participant and the symptom of the scales. And as you showed, especially female Turkish immigrants demonstrate high depression symptoms. Why especially female participants show in comparison with male Turkish immigrants?
I think our female patients have lower education. Female immigrants still have this double trouble, as we say, double trouble. They do all the homework, they take care of the children, and they additionally go working, what they would probably not do in Turkey. They have way more pressure in daily life. And the jobs they do are of lower quality. Even if they have a good education in Turkey, the first and second generation up to 2000 was not able to transfer their education levels to their life in Germany. So they mostly had to choose lower status jobs. And these women have sometimes even cleaning jobs, housing jobs, and they work hard with their bodies. and still they go home, have a very patriarchal system, and their husbands don't help much at home. We also have immigrant brides. We have women who came after marriage to Germany, and sometimes their German skills is not enough, and their other factors who give them high pressure in daily life. Immigrants living in Germany in diaspora are more conservative than immigrants in Turkey. They have pressure from their from the mother of the groom, and they live together in one house, and they don't have their own apartments and so forth. It's a lot of pressure on the women, additional pressure. There's even research, if you're interested in this immigrant female destiny question. In England, I've read a lot of papers about Pakistani and Indian women married who, when they get married, have so much more pressure in their daily life that they die earlier as if they didn't marry. And the men are better off getting married because the women take care of them and of their needs and everything else, the children and so on, and even work. And the female population, immigrant population in European countries from especially Southern Europe and also India, Pakistan, and so on, is in a higher strain and stress and has a less good life, and they also have more suicidal thoughts, and they also have more suicidal attempts, which is also a study we had in Germany, and also in Great Britain. We have a lot of studies about these women, and they do, some studies show 6 or 10 times more suicide attempts than German women, which is horrible. So that's one explanation. We also have our next session in a few minutes. I just wanted to do a tiny little break, and in 5 minutes our next session starts. I'm very happy if you want to join again. This is going to be about another aspect of our research. Thank you so much to everybody who joined this session today. I'm very pleased that you were in such high numbers. Thank you so much for joining, and please come to the next session. Goodbye.